Hello, this is Debbie Lynn Toomey, Tufts Medical Center's Injury Prevention Coordinator, and you're watching Aging Strong, which is sponsored by the Quincy Health Department. Today's topic is on chest pain, and what better guest to have than an ER doctor? We have, once again, Joshua Sheehan, one of our ER doctors, and his complete title is Emergency Medicine Physician of Tufts Medical Center and Assistant Professor at Tufts Medical School. So Josh, welcome.
Thank you. I'm glad to be back.
So today's topic is on chest pain. And as a nurse, I've worked in the cardiology department, and I've certainly have taken some family members to the ER because of chest pain related symptoms. So, it's an important topic to share, as you know, and would like to learn more from you as an ER doctor about what it is, what chest pains is, and what to look out for, and hopefully how to prevent that, so that way we don't have to go into the ER for these type of, discomforts.
Yeah. No, absolutely. I think this hopefully will be a good kind of overview for people and try to, kind of normalize to what the expectation is and, when you should go to the ER and, why, a lot of doctors over the phone might, recommend you go into the ER, even though you would like to see them in the office. And kind of, just giving a lot more generalized information about all the different tests that are run. Because a lot of times in a busy ER, the doctors might not have as much time as they would like to explain everything in great detail, which is, a problem. But, hopefully this will serve to kind of educate everyone for their family members, themselves in the future. Because really chest pain kind of, everybody knows somebody that has some type of chest pain. And there's all sorts of causes, and sometimes they need to be worked up in different ways in different emergent levels.
I think you have some slides to show us just to kind of help with your discussion.
So one of the first, questions is what causes chest pain? And so chest pain is really kind of, referred to, really from the complaint of patients and, you and everybody and what they are experiencing. And typically it's having pain kind of somewhere in the upper part of the chest. However, what we break it down into kind of in the medical world is multiple different kind of categories for what causes that pain. Not all chest pain, actually most chest pain is not caused from the heart itself. When the chest pain is caused from some aspect of the heart, a lot of times the term that is used is something called angina. Patients often will come in and, that might have heard this term before, and they're saying, my doctor says I have angina. And what that is referring to is a whole host of things that have to do with the heart. Does not mean that it is a current heart attack, but that the symptoms or pain that someone might be experiencing could be related to the heart and therefore needs to be looked at, more closely. However, there's all sorts of other common causes of chest pain. I think the most common one that people experience is digestive issues. A lot of times acid reflux can present very similarly for patients to a heart attack, which is, can be reassuring if, you think you're having a heart attack and it's, from the digestive, but can be difficult to tell the difference and make it challenging for patients. Some of the other kind of common causes are lung disease, whether this is actually a pneumonia, whether this is kind of an other underlying kind of illnesses or something called like a blood clot in the lung. And then there's more common causes like musculoskeletal issues. And we'll kind of get into each of these a little bit further as we go. But again, there's lots of things that can cause chest pain. And there's a whole host of other kind of heart conditions as well that are not necessarily a heart attack. And we'll go through that as we go through the presentation. So one of the common questions is, what does a heart attack feel like? It can feel different to everyone, but some of the classic kind of symptoms are the stabbing or squeezing chest pain or discomfort. Not everyone really describes it as a pain, but almost everyone will say they notice something, it's different. They're like, doc, it's not a pain, but it feels just heavy on my chest. In terms of from the medical perspective, we kind of view that all in the same kind of light, whether it's truly a crushing kind of pain or a pressure feels like something is sitting on your chest. those kind of descriptions or signs are fairly concerning types of characteristics of chest pain or pain that takes the breath away. The location of this pain is often kind of in the center of the chest, usually the left side. That is where the kind of the heart, kind of lies. And a lot of times that pain though can radiate, in meaning spreading to different parts of the area. Some people might feel it in their jaw or their neck, and then sometimes it can go down specifically into the left arm, but sometimes even actually into the right arm as well. And that kind of radiation of pain is also can be concerning for heart disease causing the pain. There are some other associated symptoms that we would always be a little bit worried about. If you're sweating kind of with the pain, having shortness of breath with the pain, if you actually pass out with the pain, or have a numbness in your hands or arm, or nausea and vomiting, all of those symptoms kind of together with chest pain are more concerning and definitely something that should be evaluated if it's not familiar to yourself and don't already, have an established doctor who's managing that. One of the things that I want to stress, and we'll kind of come back to this as well throughout the presentation, is what can we actually do and what risks does someone have for developing cardiovascular or heart disease? They're broken down into things that you don't have control on. The older that we get, the more likely it is that there's been stress basically on the heart, that kind of plaque has built up, and that just becomes more and more risk the older that someone gets. Also, gender, males tend to have this at an earlier age. There's also genetic predispositions. Some, if you knowing that you have a family history of heart disease, one of the things that I always specifically ask is any, heart disease at a younger age. Someone in your family having a heart attack in their late 80s or 90s might just be simply from, age, not necessarily that there is a strong genetic component, but patients having family with heart attacks at a much younger age, their 60s and 50s, or even younger, is definitely something that there could be a genetic predisposition to. And then there's a lot of things that can be modified. Some of those are just things that you can do on your own without even seeing a doctor, getting good physical activity. It doesn't have to be high intensity activity. Walking up to 20 minutes a day can lower your risk for cardiovascular disease. It's a really protective factor, especially as we get older. Other things, controlling kind of not smoking. Smoking is a really strong risk factor. And it's never too late to quit smoking. After about 10 years of stopping smoking, there's a significant decrease in your risk for various types of cancers and heart disease. So again, that 10 years really can make a difference. It's never too late. Other things are things that you want to, manage with a physician. So controlling your blood pressure, controlling if you have diabetes, and controlling your cholesterol. These are all things that are readily available for us to test and treat. There's one thing that I feel like there's a little misnomer in the community. People are always concerned about their blood pressure. And it is true. I want people's blood pressure to be well controlled. When the blood pressure is elevated for long term, that's when it puts stress on the heart and causes a risk factor. Having, one episode of high blood pressure at home is not always something that you need to be as worried about to cause you to all of a sudden have a heart attack. Again, it's the prolonged duration. So it's the managing with your doctors and keeping that under control over time. And don't be discouraged if it's not perfect. Anything that is kind of getting better is going to decrease that risk and kind of manage with the doctor. If it's really, really high, that's a different story. But some people come in, their blood pressure is just a little bit elevated compared to their baseline, and they're seeking guidance. And I like to reassure them that, it's something that is more about the time that you're having that elevated blood pressure that causes the risks. So let's go into a little bit how the heart actually works. So there's two major parts of the heart. There's an electrical component, and this is the conduction of the heart. So you have basically your heart has a pacemaker. It's called the sinoatrial node. And this generates an electrical signal that causes the upper chambers of the heart that we call the atrium, and they contract. And then that signal is passed through something called an AV node and goes to the lower parts of the chamber. These are kind of the workhorses of the heart that pump the blood kind of back and to the rest of the body. These are called the ventricles. And that's how the conduction of the heart works. Blood flow starts in the right side of the heart. So blood returns from the body and then goes to the right side of the heart. It is then pumped through the pulmonary artery to your lungs, where it actually picks up oxygen and gets rid of any kind of waste products. And then it comes back to the left side of the heart. Now it's oxygenated. We call that the red blood. And then it basically goes through your aorta, your ventricle squeezes really hard, and goes to the rest of your body and is able to oxygenate and get your tissues kind of the oxygen that they need. And that's a lot of the main function kind of the heart. One thing that's really important to know, though, the heart is of itself its own muscle. And just like other muscles in your body need to get oxygen and need blood supply to work, the tissues, the heart also has its own blood supply. And that's something called the coronary arteries. So what a heart attack actually is when the coronary arteries are affected. Some people, and this can then cause decreased blood flow to certain parts of the heart, which causes it not to work properly. But it actually starts from the blood supply of the heart itself. This is commonly caused by cholesterol buildup and these fatty deposits that kind of build up over time. And what can happen is they form plaques and basically decrease the flow of blood. Most of the time, the blood still has some flow, but it might be diminished. And what happens there is there's a mismatch. Say you're walking up the stairs, your body needs more energy and your heart needs more energy to walk up the stairs to pump the blood. But if there's a blockage, even if it's only partial, the coronary arteries might not be able to get enough blood flow to that part of the heart or the muscle to pump that blood. And you might develop some chest pain and can be indicative of one type of heart attack. What we worry about and what some people have, see in the news when people have sudden onset of chest pain and really scary, heart attacks is something called a STEMI or an ST elevation MI, meaning myocardial infarction. This is the term that we give to basically a full-blown heart attack where there's a complete blockage of one part of the coronary arteries, that there's no blood flow going through. Your heart has multiple different coronary arteries that supply different parts of the heart. Some of them are more important and can be more critical at each part, but they all play an important role. And if you have a blockage in one, this is something that can lead to permanent damage of the heart if it does not get unblocked. Sometimes what happens is the plaque was somewhere else and then it just broke off and it gets clogged at the smallest maybe portion of that artery. And that's how it can happen just all of a sudden. You might not have known that there was even plaques in the coronary arteries, but having them there, they could break off. There's other types of blockages that are incomplete blockages. And these are termed kind of from the doctor side, or NSTEMIs, or non-ST elevation MIs. And we'll go into kind of what that means and how we figure that out. These still are very important and need to be treated, but the timing is typically, people can be more stable over a day or so. But again, it could also change quickly. And both of these are types of heart attacks that need to be in the emergency room and need to be admitted to a hospital. So when you get to the hospital, one of the primary things that we do to try to figure out, is somebody having a heart attack or there any problems with the heart, is an electrocardiogram. I think there's a lot of familiarity with that kind of term, especially in kind of TV shows and in movies. It's also called an EKG or ECG in some instances. All of this is referring to the same thing. And basically, it's these 12 electrodes that go basically on the chest, and it looks at the conduction of the heart, the way that those electrical signals are working. And it kind of puts this into a graph form that you can see here at the bottom. It's not important for you to know how to read these graphs. That's a whole specialty and hours of training of trying to figure that out. However, each area correlates to a different part of the heart, and you can basically put them together and it creates a picture of what's going on inside the heart. There's other tests that are typically performed in the hospital, and these are blood tests. A lot of times we'll obtain many different types of blood tests to try to figure out, do you have high cholesterol? Do you have other electrolyte issues or something else that's causing what we call like a mimic. But one of the good tests for basically an acute heart attack is something called a troponin test. This is basically, troponin is a kind of biomarker that's produced in the heart and actually sometimes in other tissues. And when the heart is stressed, the easiest way to explain is basically it releases some of this troponin and it can be detected in the blood. So when someone's having a full heart attack, that level is going to be really, really elevated. The level is not always elevated initially. If you happen to be having chest pain immediately walking next to an emergency room and walked right in, the initial level of your troponin test might actually not be elevated. It takes a couple of hours sometimes to see that elevation. So oftentimes we will also obtain a second troponin test about 3 hours later. And that's to really kind of reassure us that there's not anything that's ongoing that we might have missed when we took a screenshot in time when you first came in. And so that's the term of serial troponin test. And that's probably the standard that you'll be used to for most people that come into the emergency department. There are some kind of places now, actually Tufts is one of them, that just went to what's called a high sensitivity troponin, where we're trying to be able to detect that at an earlier stage. So there's less delay in kind of, if somebody has a reassuring exam and EKG, maybe can actually discharge them sooner than we could even last year. Once you get the EKG and blood test and some other testing, depending on kind of what your presentation is like, one of the things that your doctor might order is something called a stress test. A stress test, there's multiple different types of them, is basically putting right now your heart might look okay on the EKG and the troponin test. However, if you exert yourself or we stress the heart, it might show signs that there's a partial blockage somewhere. And sometimes that's the only way to actually figure that out without doing kind of more invasive testing. In some cases, we recommend this test to be done in the hospital. And this is for someone with a lot of risk factors and where we think that it might be positive. In other cases, it's something that can be arranged by your primary care doctor, or they might do as an outpatient. And then we might get more information. And again, that's going to be up to kind of your doctor and your risk factors. We're going to go through just a couple of those different types for you. The most common one is an exercise stress test. And this is a test where you actually walk on a treadmill, and they do very similar testing that we just talked about. They're going to hook you up to an EKG machine. And basically, when you get your heart rate up to a certain level, your body and heart will be stressed. And it's not a bad thing that it's stressed, but we want to see, is there any kind of changes on your EKG that would demonstrate that there actually might be a problem there that we couldn't see when you were just sitting kind of in the bed or at rest. They also do some other monitoring at the same time. And this can only be done if you're able to walk on a treadmill to get your heart rate up a certain level, and you have to have certain normal enough EKG. There were other types of EKG abnormalities that are not related to having a heart attack, but can make it hard to interpret the EKG itself. And so it doesn't mean that anything is wrong with you or your heart. There are just some conduction changes that happen sometimes with age and other issues that can make this test be harder to interpret. There's another test that your doctor might order called a nuclear stress test. And this is a test where you have two things. You have two types of dyes that are injected. One of them is a dye that actually is able, like a gamma radiation, that is a nuclear tracer that you can actually see in real time what the heart is looking like and if there's any stress in it. However, you're not walking on a treadmill, so they need to also stress your heart. And there's actually medications that they can give you that are short acting that basically make the heart squeeze harder or faster. And this can basically stress your heart for a brief episode while you get the imaging. This is something that doesn't require to walk on a treadmill and actually can be, really, quite diagnostic and helpful for doctors. There's a couple other tests that they can do. And one is called an echocardiogram. And that's an ultrasound picture of the heart. And this is something that can be done in kind of a lab, or can be done as an outpatient, or sometimes done kind of in the emergency room setting as well. And this, the benefit is, can show if one part of the heart is not squeezing correctly. If one part of the heart is not squeezing correctly, that could correlate with one of those areas where the coronary artery is not supplying enough blood to the heart. It also, though, it can find other issues with the heart that could be another explanation instead of a heart attack to explain your symptoms. One of those is something called heart failure or valve disease. We'll talk about those a little bit later in more detail. There's a new type of study, and this is a special type of CT scan or CAT scan that specifically looks at the coronary angiogram. This is not available in every emergency department. I have a feeling that it will be in the next 20 years, and it's starting to show a lot of kind of advantages. But it's basically a special type of CT scan and special type of radiation that you can actually in real time look at the coronary arteries that supply blood to the heart. This is some recreated images on the bottom field here that really kind of show those coronary arteries. And what you can see sometimes is you'll see narrowing if there is an issue or buildup, or in some cases you could see a pretty decent occlusion. Again, there's varying reasons that we're not going to go into for kind of why your doctor might choose which one of these tests or a combination of these tests. But these are some of the things that when they do order them or talk to you about, this is what they're referring to. The hallmark of diagnosing, though, an actual heart attack. So sometimes you'll come in and your EKG or your troponin test will kind of make it clear that you need to have this definitively ruled out. And sometimes, again, it might be everything is reassuring, but we want to do a stress test to really make sure. However, in those cases that we think that you definitely need what's called a cardiac catheterization or angiography. This is performed by specialty cardiologists called interventional cardiologists, and it's done in a hospital setting in something called the cath lab. A lot of times, this is what is done kind of emergently when someone is having a heart attack. There are other instances where people maybe you had a positive stress test, meaning the stress test was concerning. This is the next step that they would do to further evaluate. And what it involves is you're actually awake for the procedure, and they go in similarly to the way they would put an IV in, but they put a catheter that's a little bit larger in either your arm or in your groin, and they actually are able to go in with a little bit of like a wire and a camera and look basically or inject a dye right above where the start of the coronary arteries are. And what they look for, and I'm going to show a kind of a video here, is this is actually what it looks like in real time, what they're seeing. And so when they put that dye in, it goes to all the coronary arteries. And what they can see, though, if there's a blockage in one of those, the dye won't go through that area. And you can diagnose basically that there's a blockage there. Sometimes there could be more than one blockage. And the cardiologist basically able to use that imaging and to try to figure out if there's a stent that is needed, and they need to do the next step, which is to kind of open that area or that blockage up. So kind of in summary, if you go to the ED kind of with chest pain, what you can expect is early on to get an EKG. This might be while you're still in triage and not in a room. If there's something very concerning on the EKG, you'll probably be brought back more rapidly. And that's kind of the hallmark of screening. Actually, part of the stress of my job is no matter what I'm doing at any time in the ED, the EKGs need to be read in real time, because if there's something going on, we need the person brought back. So we constantly, as emergency providers, are reading EKGs and basically screening them, for those type of heart attacks that I talked about earlier, is called STEMIs. If you have an old EKG, this is always can be helpful to have a picture of it, or just know where your doctor might have that kept in the records, because there are some types of changes on EKGs that can be chronic and make it difficult to tell if there's something else happening. However, knowing kind of what a previous one looks like is really makes it easier to compare. Your doctor may also order a chest x-ray, and this looks at the size. You can actually see the size of the heart and look at the lungs. And a lot of times this is screening for other things that could be going on other than a heart attack. Again, we talked about the blood test, and then sometimes that repeat blood test 3 hours later. And that's kind of probably part of the standard of care right now, unless the first one is so reassuring and that you're, an otherwise healthy person. They might also try to give you aspirin or other medication called nitroglycerin. So aspirin is a medication that is, that's commonly used for pain and other things, but it actually has protective component for the heart, specifically when having an actual heart attack. It's something that the EMS services might give you, or the doctors in the emergency room. The other medication, nitroglycerin, is something that people put under their tongue. And what it does is it actually dilates those coronary arteries very slightly. And what that does is it allows a little bit extra blood flow. The idea of this is that if there is a blockage and you dilate a little bit, you'll get more blood flow, and actually the pain will get better. It doesn't always mean that the pain is related to your heart if you are given nitroglycerin and it works. It actually also dilates other things. It can help symptoms like heartburn and other things. However, you should not be using this as a treatment for heartburn, but it's just a thing to know that the doctors might use. And you might have been given a prescription for it in the past if you have more chronic chest pains. One of the questions that I always get is, what do I need to do after an ED visit? So just because a doctor is discharging you from the emergency department after you came with chest pain does not 100% mean that there's nothing wrong with your heart. It just means that it's not as emergent. Basically, there's so many people that have chest pain that we can't admit every single person to the hospital. And there's a lot of different criteria that we use to basically show that you're safe to be discharged with a follow-up with your primary care doctor. One, it's really important that your primary care doctors stay in touch with, if you've been in the hospital. They should know about this. We recommend you calling them every single time you go to the emergency room, so that they know to follow up and make sure that if there's any new medications or any new diagnoses. However, a lot of times what I'll tell people is that I want you to talk to your primary care doctor about scheduling a stress test or an echocardiogram, or one of those other tests that we talked about as the next step line of, what could be causing the pain. And just because you got discharged does not mean that something couldn't happen. So if your symptoms get worse, you need to talk to your doctor or come back to the emergency department. Specifically, those symptoms that we talked about earlier, if you're getting short of breath, sweating, nausea, vomiting, kind of with chest pain, all of those really would want you to come back to the hospital for. Some of the other testing that they might do is they might give you something called a Zio patch or a heart monitor. This is if they suspected that there might be an arrhythmia or some type of funny rhythm that's causing some of the chest pain. And it's something that you can kind of wear on your chest for a couple of weeks, and then it sends it back and they kind of review the images. So kind of going back to when we had that cardiac catheterization, and say we found a blockage. And this is, again, it's fairly common for that to happen. What typically happens in treatment is something called a stent. So this is kind of a picture here of what one of the coronary arteries, and say that it was, partially clogged or, fully clogged. What they do is they go in kind of with this pretty cool technology, kind of this either metal or balloon stent. And basically they open it up, and it is able to open up the actual artery itself, and they actually leave it in there. And basically now you have good flow through there. Most of the time when they do that, they're going to start you on a blood thinner, because now that you have this stent in, you want to make sure that that stent doesn't get clogged. And in the first couple of months, that's where that risk is the highest. And so they'll typically put you on either medication like aspirin or a different type of antiplatelet blood thinner called Plavix or clopidogrel. Sometimes they'll even put you on both, or in very rare cases, but sometimes they'll put you on 3 types of blood thinners, something called Eliquis or warfarin or Coumadin in addition to these. But again, that's going to be up to the very specifics of your cardiologist and the stent in your kind of condition. But it's good to know that if you did have a recent stent place, it's more likely than not that you'll be put on some type of blood thinner. So you have to be wary if you were to fall and hit your head or cut yourself, that you will have increased bleeding to kind of prior. One of the other things that can be done is something called a cardiac bypass. This is the other term for that is a CABG that you might have heard of. This is when there is a multiple kind of coronary arteries that have disease. And instead of putting stents in multiple different coronary arteries at the same time, what they can do is actually create a graft using your own other blood vessels. So they'll actually take a blood vessel, sometimes from your leg, sometimes your arm or other area, and they actually are able to basically make a vessel that goes around the coronary artery and around that blockage. And this way, you'll still be able to get the full blood flow. And when there's multiple coronary arteries involved, this can be a preferred treatment for patients. This is something that is a little more invasive than what we talked about before. And this is done by a cardiothoracic surgeon rather than a interventional cardiologist. There's a lot more of a recovery period. However, if you have multiple coronary artery disease, this might be what you need. A lot of patients here will also be on blood thinners and will be kind of sent for a cardiac rehab. And again, there is an actual open incision in these cases. So a lot of patients post-operatively will have a little bit of increased pain because this is more of a in-depth surgery compared to the stent placement. Some of those patients might be able to go home the next day. Again, there are things that you can do to try to decrease your risk to develop coronary artery disease. Some of those are smoking cessation, kind of good control of your blood pressure, good control of your diabetes, weight loss, and physical activity. The physical activity does not need to be that much. 20 minutes a day of walking is enough and really has a protective factor for your heart. So I want to make sure that everyone stays active as best you can and really, can help. And some things, they will happen, and you just have to be prepared to, seek help and kind of, have a good support system. So remember, there are plenty of other things that cause chest pain, not just having heart attacks. All right. And so I'm just going to go into a little bit more about that and what, might be some signs of that and how that would be treated. So the first one is heartburn. So the cause here is there's too much acid in the stomach that goes up into the esophagus. So a lot of people will feel it kind of in their chest. However, like I said, the pain can sometimes feel similar, especially in older folks, and particularly folks with diabetes. They might have a slightly different presentation for heart attack, and it might feel more similar to kind of a heartburn. Women as well seem to present a little bit less typically, kind of when they're having a heart attack. So I always caution people to, still get an EKG if they're having kind of what is new type of chest pain, even if it could be related to heartburn. Typically, though, the heartburn is from they had recent spicy foods, fatty foods, caffeine, alcohol, or you could have just a genetic predisposition or have a small ulcer that's causing some of that burning. Sometimes people will have some belching. It might be better, might be worse at night when you lay down because all that acid kind of goes up into the chest. The treatments are typically acid reducers such as Tums, there's Pepcid, there's omeprazole, Maalox, Froloids, Mylanta. There's a whole pharmacy section kind of on the treatment of heartburn, but you can talk to your doctor once that you kind of have this established as what the cause of your pain is. There's another term called heart failure. And heart failure is kind of a tough term. So it's not that the heart is totally not working. It's just not working the way that it should. It's not pumping and squeezing the way that a normal heart might work. This can be something that is very dangerous and concerning. However, it can also be managed with medications. And I like to stress that because I think a lot of people, when they hear that term, they really think that that's, could be the end, their heart has failed. However, sometimes the heart can actually improve over time, and other times it doesn't. And it is a concerning diagnosis. And there are a lot of people that get hospitalized for this kind of every year, but it can be managed. There's two main types. One is called systolic, meaning the heart isn't squeezing the right way. But then there's another one called diastolic, and it actually squeezes okay, but it doesn't relax. And because it doesn't relax, the ventricles and blood doesn't get filled up the way that it should be. Either way, the kind of diagnosis is usually made by an echocardiogram. They can basically measure exactly how your heart is squeezing, whether some of the blood is flowing in the wrong direction because it's not squeezing correctly, and many other things. There's all sorts of causes of heart failure. Sometimes it can be caused from a heart attack. And what happens is, you had the heart attack and part of that muscle basically, died or got really, sore and is not working the way that it should be anymore. And that's, one kind of common cause. But sometimes it can be actually from bad infections, or there's even something called a stress cardiomyopathy, when people are really under a lot of stress or acute sadness, that the heart basically can stop squeezing the way that it should be. And some of those can get better over time, and some of them need kind of more advanced treatment. The typical symptoms for somebody will be just kind of generalized weakness and fatigue, especially with activity. And most of this is based on when you're kind of exerting yourself, your heart is not able to keep up. It's not pumping enough blood flow, so you might get short of breath when walking. The other thing that can happen is some of that fluid gets built up, and you might develop some fluid in your legs, or you might develop some fluid in your lungs that causes it hard to breathe. It can also cause chest pain, dizziness, leg swelling, and many other symptoms. The treatment is typically around types of fluid pills and other blood pressure medications. And then there's a whole slew of specialized kind of heart medications that you would need to talk with your doctor and cardiologist about. There's another common condition called atrial fibrillation. And the way that earlier I showed an EKG, normally your heart beats regularly. It goes boom, 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 and it's all from that conduction. However, sometimes what can happen is that conduction is erratic. And you can see kind of in this diagram, the normal conduction here. And then what can happen sometimes is you develop this thing called atrial fibrillation, where the atria, the signal is not being sent in an organized way. The way I describe this to patients is that their heartbeat is actually irregularly irregular. That is a very confusing term, but basically there's not a set pattern to how the heartbeat is beating irregularly. It's not that it skips every third beat. It's in a constant sense of disarray. Some patients, this is something that is very common, and your ventricles are still able to beat correctly, and that you won't have very many symptoms, and people live with this their whole lives. Some people, especially if it's a new onset, it might feel funny and it might cause some discomfort or pain, depending on, again, your familiarity with it. Sometimes when the heart goes really fast because of this, you might feel some chest pain. And sometimes the heart can actually go really slow because of this as well. So it's just something to be kind of aware of. And that's where that Holter monitor might be important if your doctor, maybe by the time you got to the hospital, you were feeling better and actually you're back into a normal rhythm, because your heart can go in and out of this rhythm, which can make it hard to diagnose. The treatment is typically medications to kind of control the rate or the rhythm, or in some cases you get an ablation or even a cardioversion where they can basically shock you back into the right rhythm. And again, that's going to be depending on your situation and kind of your doctor, but but it's just an important thing to be aware of. One of the other ones we talked about was costochondritis, or muscle pain related in the heart. So this can be from actual muscle itself. So, somebody was lifting a heavy box and they actually, strained one of their pec muscle, which is right over the heart, and it can be really hard to tell. A lot of times we have to still do some of the testing to make sure that your heart looks okay underneath the muscle. A lot of times in this case, though, the pain will be reproducible, meaning, you're kind of touching the area and it hurts to touch. However, it's not, that doesn't necessarily mean that you're not having something else, because sometimes when you're having really bad heart attack, it might feel painful to touch just because the whole area is inflamed. However, this condition called costochondritis is actually also pretty common, and it's where the cartilage itself, so it's not even the muscle, it's the cartilage of your rib cage gets inflamed and cause a really severe kind of pain. Sometimes that pain worsens when you're breathing in, and that's because your ribs move when you breathe, and it's kind of hard to rest it. So when you kind of injure your arm, you might rest that arm and it'll kind of heal. But sometimes this type of pain can last for several weeks because it's hard to actually fully rest. You still need to breathe every day, every day. And can be a really kind of hard diagnosis. We call it a rule out diagnosis, meaning it is still common, but we need to, there's no test that I can do to 100% prove that that's the cause of the pain. So I typically would like to get an EKG and some other tests to make sure that the heart looks good, even if your exam is suggestive that this could be the cause. Then there's a whole slew of kind of lung diseases that can cause chest pain. Your lungs actually take up a very large area of your chest cavity. It goes from basically here all the way down almost to the end of your rib cage where you can feel. And if you have an infection in there, if you're having trouble breathing, that can actually present with pain, and is an important kind of indicator, and is treated different than if it's, the pain is coming from the heart. There's things called COPD, or chronic obstructive lung disease. There's also conditions called a pulmonary embolism, meaning a blood clot to the arteries of the heart, and basically, or of the lung. And kind of that's similar to kind of heart disease, where the lungs are the ones that are not getting enough blood supply because there's a blood clot somewhere, and then you kind of feel that as pain in the same way. So it can be really hard to tell, and there's a lot of things that we could go into, but I think just being aware that the lungs have a whole array of issues that could present with chest pain is kind of important to know. And so I kind of want to just kind of circle back to kind of what a heart attack feels like. So again, stabbing or squeezing, pain, or just discomfort. Again, it can feel like a tightness on the chest, and it typically is kind of in that pattern here that we're talking about. But again, patients, as we get older, the pain receptors actually change, and sometimes can present very atypically. Sometimes I've seen many cases where the presenting symptom was just kind of shortness of breath and fatigue, or sometimes just vomiting, and kind of just a feeling of something being wrong. And everyone might have a slightly different kind of feeling. Some people will have a condition called stable angina, and this is where their coronary arteries might be a little bit tighter. There might be a chronic partial blockage, and the doctors felt that it wasn't amenable to a stent. However, every time that you go up a certain number of stairs, your heart is stressed, and it might cause kind of some more symptoms. This is something that needs to be managed very closely kind of with your doctor, because if it ever gets worse, that could be a sign that narrowing is worse and needs to be reevaluated. But some people do kind of get the symptoms on and off. Again, I stress that everybody, if you're having kind of new chest pain kind of for yourself, especially if there's any of these kind of associated symptoms, you need to either get seen by your primary care doctor or come to the emergency room. Patients sometimes are frustrated when I diagnose them with something that's not related to their heart, and they called their primary care doctor and told them to come in. And this is a really hard condition for patients to know what's going on, and for doctors to know what's going on without getting an EKG and some blood tests to kind of reassure us. So it's not that your doctor doesn't want to see you in the office, but a lot of times the emergency room might be the only setting that you can get those tests done quickly to make sure that something not emergent is going on. But that also doesn't mean that there's not something else going on that needs to be worked up kind of as an outpatient by your primary care doctor. So I think that's kind of the crux of what I had to talk about. I'm happy to kind of field some questions and kind of go back to any of the slides if you want some more information. I know there's a
So
lot there.
you definitely did, oh my gosh, you covered so much, and I really appreciated how you also added other factors that can contribute to chest pain, meaning lung disease and digestive problems, musculoskeletal. Can you just can you walk us through? So, let's say somebody's at a party and then all of a sudden you hear like a scream, or like, a big, crowd is going wild over, this part of the room, and you see somebody clenching their chest. What would you suggest for that person or people around that person to do? Would you say, oh, have them go see their primary care doctor, or would you have them say, have them to go to the ER so that way this person can be seen?
Yeah,
It's
no, absolutely.
walk the people through like a scenario so that way people will know before a chest pain happens what they should do.
Yeah. So kind of in that scenario where someone's and this is a common scenario of, kind of people that I see when it's really that severe of a kind of sudden, someone was fine, they were, maybe out doing something, then all of a sudden they get really bad chest pain that, they visibly look like they're in pain, they're really complaining. Sometimes if they're sweaty, if they're like something's wrong with my arm or my jaw, or they're having trouble breathing, you should call 911 almost every single time for that case, unless it's a patient or somebody that knows already that they have a condition and that this happens frequently and their doctors have worked them up many times before for it. This is something that should be evaluated in the emergency room, because one of the issues is time is really important. If there is a blockage, this is something that we like to get done as fast as possible. We have all these protocols even to speed it up once they get to the hospital, and kind of why the EKG is done basically in triage for all of these kind of patients. What's even better is the EMS team. If you they can do the EKG on scene, and they're trained to kind of identify not everything, but identify very concerning kind of factors. And again, things can get bad in some of these heart attacks really quickly, and can happen at a younger age than kind of I think what people traditionally think of. So in that kind of scenario, I think be prepared to call an ambulance and get that person to an emergency room. And if it turns out that the EKG and is all reassuring and they feel better, that's great. But the alternative is too high of a risk. If it's something more, you're having someone complains to you that they've been having pains for a couple of days. You're like, oh, every time I go up this, the stair, that's something that maybe you can go to your doctor first. Again, in that case, it depends on kind of some of your risk factors and what your doctor knows about you before. However, if that's totally new to you, having kind of a new chest pain really a lot of times needs to be an emergency medicine workup. And it's okay if the workup is reassuring. I want it to be reassuring. We don't want you to, I think sometimes people are afraid to come to the hospital because they don't want to be told that it was just nothing, that they were having, a panic attack, or that they were, had reflux. But again, the risk of not coming in, and there are plenty of people that I see that really they wait a long time, and sometimes there's damage that's done from waiting, and we can more readily reverse things quicker. So again, we call this, when somebody is actually clenching their chest, it's called a Levine sign in our medical textbooks, and that is actually a pretty concerning when somebody is in that much pain that they're kind of like visibly in pain. That person probably needs to be seen in the emergency room pretty quickly.
Yeah, thank you so much. Time matters, which suggests that calling 911, like you said, is really important, as opposed to like having one of the family members driving that particular patient or that person to the ER because they might hit traffic. You just don't
Yeah,
know. Speed is in the same, would be on their side. And that's where the EMS would come in for so many different reasons. Like you said, they could start an IV maybe, or check the vital signs, blood pressure, heart rate, and do the EKG. So once they go to the ER, and hopefully they are under the care of the EMS people, the ER is prepared to receive that person, correct? So that way,
correct.
yeah. And what do you usually recommend when somebody goes to when somebody's taken by ambulance? Should a family member accompany the patient, or should the family member um, meet the patient there in the ER? What is the best
Yeah.
suggestion?
So it's always ideal to have somebody kind of there. A lot of times the ambulances won't kind of allow somebody to come back in the ER depending on or in the ambulance itself. It depends on the exact kind of scenario. So kind of trailing along and kind of meeting at the emergency room is really important because sometimes when we get there, there's really important things that can happen quickly, and we want everyone to be informed, and can be really anxiety and scary for kind of patients. So allowing, having family there. I think sometimes there's frustration that this has been a little more common since the COVID pandemic, that family members have not always been allowed back in the emergency room due to some of the infection control. And I would still argue that having family kind of there is really important. We will grab, family for when there's that, significant of if it's a true, heart attack. Um, and sometimes patients that come in, they're in a lot of pain, and it can be hard to make good decisions and understand kind of everything that's happening. Sometimes we're giving them pain medications or morphine, and they, they're might be a little, fuzzy and not be able to remember everything. Also, a lot of people's better halves are much more knowledgeable about about that person's medical problems, especially when you're in a state of distress, kind of telling them that which medication you're on, and some of your history can be really helpful to have family. So again, don't need sometimes the expectation, multiple family members are unlikely to be kind of welcome back in the emergency room, but they're always could stay in the waiting room or like a family room. And again, it also depends on kind of what's going on, and like how long they'll stay there, and various things.
Definitely, yeah. It does really help to have a family member there, but not the whole, extended family, because that can be overwhelming for the ER as well. So just designating one person to be able to be there for the patient would be really helpful.
Yep.
Is there a day of the week that you typically notice chest pains seem to happen more?
That's a good question. So I don't know. That'd be an interesting study to see if particularly chest pains, if there's more on a particular day. I do know that on Mondays are probably the busiest day in the emergency room. People kind of put things off over the weekend. They're off. They're with their and they're like, oh, maybe I had a little bit of kind of pain at that barbecue, but I don't want to go into the hospital. And then come Monday, that pain is still there, and so we actually see a lot more people come in on Monday. I don't think that necessarily Mondays have more like acute heart attacks, but we definitely probably diagnose more things on a Monday just by more patients present on kind of Monday. I don't want that to scare people away from going to the emergency room on a Monday if you're having chest pain. But it is an interesting kind of fact, and that actually has been studied pretty universally at multiple hospitals that I've worked at in the past. And pretty much always Mondays are, just more patients, and the hospitals actually staff kind of for that. We have sometimes more doctors on and more nurses on, kind of at times and days that are higher volume.
I do a lot of just as you, I'm sure, have taken a lot of blood pressure on patients.
Yes.
I typically get questions, which number is more important, the top or the bottom? And what's the top anyways, and what's the bottom? So you gave us a nice slide presentation of the heart and how it pumped. Can you just kind of briefly go over what does the top and the bottom number of the blood pressure mean?
Yeah, absolutely. And I'll try to kind of keep that in like in simple terms because the actual calculation is actually yeah more complex than I'm going to get into. But basically, there's two things. There's called the systolic blood pressure and the diastolic blood pressure. And I was going over those terms when we were talking about how the heart squeezes and the two different types of heart failure. So what happens is when your heart squeezes, the same thing happens with your blood vessels. That basically the blood flows up all the way into every blood vessel kind of in the same way as as a pulse. And basically when that maximum pressure kind of hits, we call that the systolic blood pressure. That number is always going to be higher because you had just basically squeezed and the pressure is going to be higher. There's more blood flow at a velocity there. So that's called the systolic blood pressure, and that's the top number. And then the diastolic is what that number, what that pressure is when the heart actually relaxes. It's not actually squeezing. That heart's kind of returning, to the heart itself. The blood is returning to the heart itself. So both of them are important and can be indicative of different things. In general, I think there's a little bit more emphasis on the systolic blood pressure, on what that top number is. So and it's a lot easier to kind of just understand when it's just kind of, one number. Again, there are more complex things. Having a really high low number or bottom number is concerning, and having too low of a bottom number also can be concerning for other different types of heart disease. But in general, I think we focus on the systolic or that top number. In general, the blood pressure systolic number should be around 130, and the bottom number should be around 70 or 80. Some people will have lower blood pressures on a regular basis. We see a lot of, smaller people. We see a lot of kind of women that might even have a blood pressure of 110 over 60 or even slightly lower, and that might be normal for them. So it's all relative to that, but it's usually within a pretty close range. Blood pressures can range a lot with different things. When somebody is in pain, your blood pressure, you're literally in enough pain that you actually cause your blood pressure to rise. And that is a different type of high blood pressure than if blood pressure is elevated on a regular basis. And again, not that I don't care about people's blood pressures when it's high, but when they're in pain, I actually don't treat the blood pressure. I treat their pain, and then I see what the blood pressure actually is. And so kind of checking your blood pressure, if you're really anxious or in a lot of pain, you can kind of falsely raise that. So it's actually best to kind of measure your blood pressure kind of in a relaxed setting, kind of at a similar time, kind of at a day, to try to get a best understanding. There's the term white coat hypertension, when you go into the doctor, it's fine at home, and then you go into the doctor's office and it's elevated, and that can actually be quite tricky to sometimes figure out of what is actually your resting blood pressure.
Is there one important thing that you want the viewers to take away from your presentation today? What is that one thing that you want them to kind of like really remember?
So I think those risk factors of, for heart disease, there's only so much you can do once you're, actually having, kind of a heart attack. And I hope this was helpful to get an understanding of what, the doctors and might do, but really recommend, getting that 20 minutes of exercise kind of a day, decreasing smoking, decreasing alcohol consumption, and kind of keeping kind of some of the risk factors under control. High blood pressure, cholesterol, and diet. So I think that truly is what I want to kind of, as a take-home message to help us decrease the amount of cardiovascular disease that everyone's going to have in general.
Very good. Thank you so much. Well, I want to thank you for being on the program. I'd love to have you again to cover another topic that's going to be really useful for older adults. And I want to thank the Quincy Health Department for sponsoring Aging Strong. And until next time, everybody, be safe. Take care. Bye-bye.
Thank you so much.